Oh, we're recording finally. They finally got the message. All right, everybody. I guess we're up to speed and this should be able to work. Sorry for the delay. A couple of things, effectively, we're going to be working on this PowerPoint. And I just finished the other lecture and totally forgot about it, and I'll fill you in a second. I did upload this to your Blackboard under this Unit 2, and that's this outline that you can see here. Fairly thorough. I just, again, a while ago, but it has a lot of the information I'm sharing with you about this. So I'll get back to that in a second. Just let me make an introductory remark or two before I start with the show. We got in at 4 in the morning. I'm going to make a bunch of mistakes and don't know what I'm talking about half the time here. I'm so tired. And other than that, with regard to the exam, I want to get this out in front for everybody who's here. Uh, we still have a couple of students, a handful of students who are going to be, who have to take it because of technical or other issues that were there. Uh, this does not involve everybody, so it's only relevant to them. Effectively, when this exam was deployed, there seemed to be a lot of problems attendant to with it. I went in and I corrected a lot of the errors. There are two questions I will give everybody credit for. If you got it wrong, you will certainly get it right. If you got it right, it doesn't change, obviously. One I had two answers for that were the same, so that question is going to go out. And then the other one was just, it wasn't worded enough to satisfy me, so I'm going to toss that anyway and give everybody credit. Whether you got, as long as you got it, if you got it wrong, you're certainly going to get it right. Then what I have to go in, I tried to correct the other ones, but I will go in, and this is going to take a little bit of time while I can't do anything about it probably to the earliest Wednesday to have any success. I have to go over all the exams and effectively, not so much hand score, go over the Blackboard results. And out of the 60 questions, count the number right and make sure that you get credit for any of the ones that were marked wrong that shouldn't have been marked wrong effectively. And most of the students, most of you did very, very well on it. I'm sure the grades are going to reflect that. I wouldn't stress over it. So please hold your questions or your inquiries until I can give you more information Wednesday and hopefully post grades. Again, it's all about the letter grade. So, and certainly if you go back and look yourself and if you count the number right, and let's say you got 50 out of 60, that's going to be a very good grade, obviously. All right. And so start looking at it and give you an idea of the ballpark you're in, and there are issues. We'll have plenty of time Wednesday and even Friday to address them. This is just the nature of this week. We'll not have any time tomorrow because, unfortunately, because of a family issue, the funeral is coming up. So there's a lot going on. Unfortunately, in my world, that shouldn't have to impact yours, but who knows? Sometimes it does. So thanks again for letting me drone on about that and let me get started. I sent a recording. If you had a chance to listen to it, fine. It basically covers a lot of this. I want to sort of flip through it fast, relatively, and get to the new area, which is more about anemia and the different kinds of some red cell stuff and some white cell stuff before we end up in the platelet stuff. There's a lot to cover, and you're going to find that outline to be very thorough. I spend a fair amount of time on blood because I think it's super important. So let's begin. So you should all be getting me. It'd be easier for me to talk. If I hear a ding, sometimes I have to let somebody in, but I would suspect probably not now, given that we've already started. So this is just a blood chapter. And yeah, I went into talk about the fact that it's a connective tissue. It just happens to be liquid, no big deal, weight, volume, etc. We talked previously about the differences between men and women, re the amount of blood, and a lot of it has to do with, I mean, obviously some of it may be average size, but again, we talked in the last chapter about endocrine, where there was some relevance about that. Effectively, the cells are what we call formed elements. Okay, form, because they're not all cells. The only one that's a true cell is a white blood cell, as you will see. And we revisit white blood cells extensively in the immune system. So this is the introductory part, and we're going to revisit it again and be in more detail when we get into the immune system, because they're the linchpin of your immune system, the white blood cells. Platelets are about clotting. That's at the end of the chapter. They're very important. And red cells are all about carrying oxygen and all of this is so extraordinarily vital, and it's very much a physiological system. So that's the first jumping off note. What I will spend more time on I'm going to look at the Marie PowerPoint that gives you a little bit more information as we start getting into this area. But the first little quick nugget about this, so to speak, is this called the hematocrit. The hematocrit, and you'll see it when we look at the spun down tube. That's the classic picture for every anatomy and physiology textbook. Is this idea that it's a very useful snapshot into oxygen carrying capability. It's so critical for things to people look at clinically, because it underscores a lot of problems. And what it is, as you will see, and I'll just flip to it real fast this way. This is think of what they do. You donated blood. They spin it down. They centrifuge it. Why? Because you could let it just sit there and it would probably do so, but there's problems attendant to that with clotting that's may be unwanted. Effectively, that's a very, very rapid way to separate the components, and they're all useful. Pack cells are here at the bottom. Those are red cells. They're the heaviest element of the form. They're filled with hemoglobin and protein. That's why. They go to the bottom of the tube. That's what centrifugation does, spinning you around. The liquid that sits on top is the lightest. That's called plasma. That's water with all the stuff that's dissolved: electrolytes, proteins, chemicals, hormones, you name it. All that's in there. The area, a very tiny but slightly heavy area that has sort of an off-white color called the buffy coat, are white blood cells, which basically, for every white cell, there's about 1,000 red cells. It gives you an idea of how many more there are. And platelets. Platelets are very numerous, but very, very tiny. And so they occupy less than 1%. And effectively, this is a cylinder. So if you look at the red here and the non-red here, that 45 to 55 is something we call the hematocrit or crit. That's a quick snapshot into someone's oxygen carrying capability and their anemia. And anemia is awful. I'll talk about it when we're in class on Wednesday a little bit more when I go over it a second time, particularly with regard to transfusions and blood clotting. So it'd be Wednesday or Friday. And to understand the extraordinary amount of fatigue that's associated. And anemia is a very common problem. By inference, we're talking about red cells. We just don't have enough of them. And then you don't have enough oxygen, and the system just really gets bad. Best thing I can tell you. So, quickly going back to this very good illustration, the formed elements, again, true cells, white blood cells, red cells have shed their nucleus. And because as they mature, they don't need it. They're all about oxygen. And platelets are tiny, but they're little fragments of cytoplasm and cell membrane. And the cytoplasm has clotting granules in it. And effectively, and now the plasma is all the water component and everything dissolved in it. So salts, water itself. 3 different kinds of proteins. I'll get into it a little bit more about the roles of albumin, globulins, and fibrinogen subsequently. That's something they should have spent some more time on and didn't. Waste products, talk a little bit about this. Nutrients, vitamins, we constantly are talking about. Gases are a little bit more in respiratory, but they all dissolve and they're considered plasma. And today we'll talk a little bit about and the relevance of these numbers in the differences between the 2 major cell lines of what they call granulocytes. We'll get to that in a second. And agranulocytes. These are the 5 major categories of white blood cells, and a little bit about why they're so important. That's part of today as well. So you just saw this before. We call the supernatant liquid stuff at the top, and we can siphon that off and use the plasma. We can siphon off platelets. We can siphon off white blood cells. And by and large, if you did not know, you get a transfusion of red blood cells. They're those at the bottom. We call those packed red blood cells because they've been packed by centrifugation. You very rarely give whole blood because we have a whole. Effectively, most of the time you need it for red blood cells for oxygen, and you can just supplement it with different kinds of fluid. That easily, because you have other uses for the rest of this stuff. I'll get into that a little bit more when we start talking about transfusions and things like that, which I have entirely too much familiarity with. And so all that, there's subtle differences between men and women, which we had talked about, but there's a wide range of normal. Realistically, I mean, if somebody's between 35 and 55, you're not worrying too much. And if you've addressed that there's no major underlying factors, when you talk about somebody who's a hematologist, doctors who study cancer, oncologists, are certified in what's called oncology and hematology. There's a tremendous amount of overlap in those fields. And so they have a dual certification, if you will. And they're just showing you and the different top tubes I talked about a little bit. That's a lab lecture. I'm not doing that. I do this in micro. If you got me for micro, we're going to talk a fair amount about precautions and things like that. But you can read through it as well as I can read it. And I'm not going anymore with this. These all come from a common ancestor. The term is called hematopoiesis. It's a stem cell, and it gives rise to two lines, the lymphoid line and the myeloid line. The lymphoid line gives rise to two kinds of cells, lymphocytes and monocytes. They are vital in disease fighting, vital in fighting viral infections, bacterial infections, all kinds of infections. What's interesting about the line, and you'll see that in a second, is the fact when you stain them, they don't have visible granules. The granules are in there, they're just not visible with the stain. The myeloid line, as you will see in the white blood cells, have visible staining granules, and one of the ways we characterize them, and also include red blood cells and platelets in it, because effectively there's granules, and red cells are sort of a unique thing in and of itself. So you can see there's a really, and you'll see some very good graphics about this. And why this may, and at the very end, I talked about it, but I covered it a little bit before, and whether we have time or not to do it today, I'll probably reiterate it on Wednesday. You'll hear the terms associated with leukemias, which are cancers of the bone marrow and therefore cancers of these, and typically it's white blood cells, lymphocytic and myelogenous. And it kind of tells you what cell line is involved. More on that at the very end today if we have time, or not. Then we'll do it next time. Here's the common ancestor. Here's the myeloid line. Here's the lymphoid line. And so make it easy. Monocytes and lymphocytes, and monocytes, when they leave the bloodstream, become macrophages. Lymphocytes, when they leave the bloodstream, stay as lymphocytes unless you need to make antibodies, and then these B lymphocytes become something called a plasma cell. And this is really something we cover in much more detail in the immune system chapter, and we've got a ways to go before that. We have to get through the blood chapter. Starts blood, heart, and blood vessels chapter, and blood pressure, and then immune system comes after that. So that's why this is sort of your introduction, and it's important stuff for it. The myeloid line has red cells and the platelets, and again, platelets are nothing but little fragments filled with granules. And then what you see here, these are the so-called granulocytes, because they all stain colors. Ignore the pictures for now. They're not great. You'll see better ones here. And so there's a couple of things, and that's why I like to use the other PowerPoint, because they show you the maturation of the red cell. And this is sort of incomplete. You can see what happens here. Red cells, as they mature, get smaller. They get smaller, and when they're finally mature, they shed all their organelles and their nucleus. And then they're just elegantly designed for one job, and they have one job: carrying oxygen with massive amounts of hemoglobin that are contained within that cell. That's what goes on. And so we can tell if a red cell is immature, depending on, or poorly formed, or doesn't work, or if they're going to have trouble with different kinds of anemia based on what it looks like. Is it too small? Is it too big? If it's too big, it didn't mature. If it's too small, it's probably not got enough hemoglobin. And there's an interesting thing, and they use the term reticulocyte. This is not a reticulocyte. There's an in-between called a reticulocyte, which we see in the bloodstream, and it's an important number. Almost anytime you're drawing bloods and you're interested, you do what's called a reticulocyte count. And it should be about 1% of all the red cells should be in the reticulocyte form. And what that means, let me see if I have to let anybody in. No, I think we're good. We don't have to let anybody in. Oops. Up. Sorry, going the wrong place. What's interesting about that is about 1% of all the red cells classified as reticulocytes. They have elements of the endoplasmic reticulum still there, tiny traces. And if that counts, and that plays a role in what we call maturity or immaturity of red cells, and that's really important in your ability to deal with anemia and other factors. And I'll talk about that again a little bit more in the transfusion part of the program. So, red cell, that's all it means, red cell. And I did all this before. It's designed. Third of it's hemoglobin, but it's massive amounts of hemoglobin. There are about, in a red cell, there's about 250, an individual red cell, about 250,000 hemoglobins. Each one has the molecules of hemoglobin. Each one has the capacity to carry 4 oxygen. So each red cell can basically carry, are you ready? 1 billion molecules of oxygen. And since we have immense amounts of red cells, I mean, in a microliter, a millionth of a liter, okay? Take a look at 1 milliliter, okay? That's not even a half a teaspoon. It's like a fifth of a teaspoon, okay? You have, I can't even tell you, untold millions and millions of molecules in blood, millions and millions of molecules, billions and billions rather, molecules of hemoglobin. It's immense. When it's got oxygen, we call it oxyhemoglobin. Blood in your veins hasn't lost it. Deoxy doesn't mean without oxygen, it means with less oxygen. Typically, about 1/4 of the hemoglobin is not oxygen. That's typical for venous blood. And yeah, all the other stuff is straightforward. That's what they look like. I talked about this before. This gives you the numbers. A microliter. I mean, I can't, less than a dot, for sure. Average 5 to 6 million red cells. And so it's just so terribly significantly large. So when we look at formations called erythropoiesis, we talked about erythropoietin, the role that it plays. Yeah, the liver is active in it typically during growth and development, particularly fetal growth and development, not so much in adults. It's about the kidney. Yeah, it's negative feedback. It goes through all these stages. I'll show you some better illustrations. What's relevant about the 120 days is that if you're donating blood or anybody's donating blood, typically between 90 or 100 to 120 days of the lifespan. So they probably keep the blood for maybe a little bit less than 2 months, in the sense that after that, it's not going to be as viable. You can ask the blood bank how long they keep certain components, they can keep longer, obviously. And we'll look at the relevance, B12, folic acid, and iron, and the role that they play. And in general, when we use the term anemia, unless you're using a different adjective, it means, for whatever reason, ineffective red blood cells. Less is such an odd term, but let's say these are red blood cells that we don't have enough oxygen carrying capability. Typically, when the number is lower, that's there. And they're just showing you, kind of how this works and the controls. Nothing big deal here. Okay. B12 and folic acid are necessary for the growth and development of a red blood cell, maturation. That's why, as you will see, when we will see the most famous of these anemias by name it's not the most common. It's called pernicious anemia. It means a lack of B12. Same would occur with folic acid. As red blood cells mature, they get smaller, not bigger, not like other cells. They get smaller, more designed for oxygen carrying. So if a red blood cell is too big, okay, that's immature. And if it's immature, it's not going to have the ability, and it's going to be a kind of anemia, even though it's a big cell. We look at the relative amount of hemoglobin in the cells compared to the volume of the cell. That's something you have to know. The most common anemias involve either not enough iron or losing blood. Okay, losing blood from an injury, losing blood from an ulcer, losing blood from an accident, diseases or infections that can damage red blood cells, autoimmune phenomena, and very, very commonly insufficient amount of iron. Those, the red cells aren't bigger, they're smaller. They mature just fine. There's just not enough hemoglobin to fill them up. And if there isn't, they can't carry it. So if anything, they're paler. I'll talk more about that again when we talk about the transfusion thing that's going on. So this just gives you an idea of all the different kinds of anemia. The oddball here, okay, pernicious anemia is from B12 lack. We can take B12 supplements. A lot of people have it because they don't make something called intrinsic factor, which we talk about again in digestive. That way, B12 in your diet can be absorbed in your small intestine. People, they can still be treated because there's nasal sprays and gels and injections, so you can get the B12 fairly easily. Okay, the intrinsic factor is typically the issue. Folic acid, we don't see too much unless there's a dietary lack. We have to ingest folic acid. We don't make it. So anybody taking a B vitamin supplement, as long as they have intrinsic factor, is not going to have any problems with your pernicious anemia or folic acid related anemias. These have to do really the ones that are long term and chronic, is like what I had from a bleeding ulcer. Those are big problems. Okay, hemolytic we'll talk about with transfusion, but there's also infectious disease factors that are there. Aplastic is less about red cells than it is white cells. Yeah, all elements don't form, but because you have 1,000 times more red cells, when you stop making white blood cells, bigger problems happen faster. You have a surplus of red cells. And so the fact is that people with aplastic anemia succumb to infections. Their infection fighting ability is gone. It's kind of like having an AIDS patient. They're eventually going to die of some kind of an infection. And there's lots of things, medications. There's some have taken off the market because of that. Things along those lines, cancers, viruses, poisons, etc. Iron deficiency, very, very common. Sickle cell is interesting. Thalassemias are more genetic. I'll talk about those with blood clot because they play a role with blood clotting disorders. Sickle cell is probably the one that you have to review a little bit. That would be a common one from a board exam or a licensure exam type of thing. It's genetic. We used to think years ago that it's autosomal recessive, meaning mom has the trait, dad has the trait, 1 in 4 chance, kid has the trait. Kid has the disease because the disease you have to get that recessive from both parents. And then there's a lot of problems when they're active. If they don't get enough oxygen, the cells start to sickle. In other words, they lose their shape and they clump and they clot, and blood flow doesn't get to organs and vital structures, and it's big problems. It's extremely painful, and it can be life-threatening in sickle cell crisis. And it can cause terrible. I treated patients at a big clinic for this during a rotation at the Medical College of Virginia many, many years ago. Big pain, big ulcerations. We were treating them, all those things. A lot of damage to their skin and surrounding tissue that was there. Interestingly, we used to think just having the trait wasn't a problem. The trait is a problem because under extreme circumstances, very vigorous activity, particularly when there's not enough oxygen or at elevation, uh, sickle cell can manifest itself even as the trait. That's what happened to the athlete Ryan Clark, who played for the Steelers. He was up in Denver. He had a crisis, really life-threatening. He had to take out a spleen, which had ruptured, and his gallbladder. That's why he couldn't play at Denver anymore, and that really impacted the Steelers' ability to win in Denver because he was a vital part of a very good defense, unfortunately. So he couldn't play there again. That's from the trait. The trait is a problem in and of itself. Believe me, people don't understand. There's been nowadays they're very aware of athletes who have the trait, and there have been some criminal activity that have caused loss of life or severe injury to athletes when coaches who were hard ass coaches thought they were, they were starting to develop a crisis when they did. Well, they didn't realize how bad the trait was. Now they do. I won't go into all the stories, but you can look them up that are there. And that's an evidence that's what sickling looks like. There is sickling. Sickling. So you can look at that's more the classic sickle. Iron deficiency, you can see there's not enough hemoglobin. They're pale, and even then you can sickle with those types of things. So you can take a look at this. We won't go into the genetics of it. The blocking, the pain is extreme. Any anemia, there's one word: fatigue. I'll tell you more about it when we talk about the transfusions unit. Fatigue is so dramatic that you have to hear. I'll give you some real context when we begin to talk about it with regard to this. It's there, but I mean, the degree of fatigue is unimaginable to someone who does not have it. And there's a lot of different treatments, as you can see here. They really have improved. There's been a lot of research done with it over the years. It's become, we can understand the genetic and the hemoglobin basis, and it's really a focal point. So read through that. Understand that when we recycle red cells, okay, we're very good at recycling. The trouble is, remember the molecule's name is hemoglobin. Well, the globin is nothing more than four polypeptide chains that each hold what they call a heme unit. Hence it gets its name. Well, the globins are amino acids. We can reuse them easy. The spleen and the liver do the job. Even if you lose your spleen, your liver can take over. A ruptured spleen is by no means, as you can tell with Ryan Clark, they had to remove it. The liver can take over. It's not desirable, but it can happen. And again, they have a lifespan. What red blood cells spend a lot of time doing is fitting through little blood vessels. When they fit through little blood vessels, they can almost squeeze and bend and change shape. That's why when we use agents to prevent clotting, we have people have a tendency to clot. These agents are able to actually make them even be able to fold and be less problematic. There's a whole lot of science that's involved, but over time they lose it. Like anything else, there's a lifespan in these particular cells. So we can recycle the globin, but the heme part, we can recycle the iron, as you will see when we look at the sort of the chemistry behind it, but you don't remember it. It's the heme group minus the iron's problem. And it's this waste product that we have to get rid of, either through the urine or the feces. Okay, one of those two systems, and it's called bilirubin. Bilirubin is a chemical that has pigment. It colors the urine and the feces, giving them their characteristic appearance or color. The trouble is when it backs up into the bloodstream, if we can't get rid of it, if there's gallstones, liver disease, a blockage somewhere that prevents it, or if there's an excessive amount that forms from, let's say, an anemia where a disease is causing a breakdown, we call it a hemolytic anemia, it backs up into the bloodstream and causes discoloration. The classic description is called yellow jaundice. We just use the term jaundice. Another term is called icteric, Icteric, and that means a yellowish cast to the skin, the whites of the eyes, sometimes the lips, fingernails, toenails. That is the accumulation of this pigment that, unfortunately, if we can't excrete it sufficiently, will back up. And so you can see it. So what happens is we're able to, the heme, as you will see, decomposes into, we break it down. The iron we can recycle. There's problems with iron too, but we're not getting into it in this stuff. And so everything else is reusable, but the bilirubin, okay, are secreted in the bile as bile pigments. Okay, and we'll get to digestive, they play an important role. But again, if they back up, there's a problem. And they also, you're going to see urobilinogen, stercobilinogen, fancy names you don't have to know, but that's really this stuff getting excreted. So here's these, we got two alpha and two beta chains. And these little discs are always the way they represent hemoglobin. That's where the oxygen is carried, pretty much on the iron. But this, these two chains of organic molecules, that's the problem. We can't break those apart and reutilize them. And they go through exactly how this comes through, and you can read through this as well as I can read it to you. So that's something to remember a little bit about. And understand the problems attendant with bilirubin and backing up the idea of jaundice and the fact that it's excreted in the urine and feces and gives it its color. We can recycle everything but the heme component, the iron, even though there's some problems attendant with that sometimes, and the globins are less of a problem. Which brings us to white blood cells. We're going to see this again when we review it in the immune system, and we'll see it again when I use the other PowerPoint. There's a mnemonic that's actually useful, one of the few I actually like. It's called Never Let Monkeys Eat Bananas. And that is the pecking order of how numerous these are. The never stands for neutrophils, the most numerous. Let stands for lymphocytes next. M, monocytes, monkeys, eat, and bananas. And that gives you the idea of which are the most common neutrophils, which are the least common basophils, something you will need to remember. They fight diseases, whether there's injuries, whether there's damage, whether there's infections. They are how your immune system protects you, repairs you. They play such a pivotal role, but they don't last very long. Most of them last, we're talking about hours and days. Some last longer. You saw red cells, 90 to 120 days average. Okay. Lots of different things. When we get to the immune system, we'll talk about some of these different factors that are there. I don't want to go into it now. It's less important for us. Okay. Again, the two lines, the granulocyte line and the agranulocyte, these, remember, myelogenous. So they have granules that stain, either neutral, where they have, and red and blue are the dominant colors. Red for acid, blue for basic, and neutral is in the middle, and it's actually kind of a lilac color, the way it's described by most authors. But you can see the granules. Whereas agranulocytes, and they phrase it well, it's not, you can't see them, they're not noticeable. They're there, but they're so uniform that you don't see the granular appearance. And those are lymphocytes and monocytes. A lot of times we call those mononuclear forms because these they all have one nucleus, but these nucleus have a lot of folds. These do not. And hence they're called mononuclear forms, and that's the ones that give you the disease, mononucleosis. It isn't just monocytes, it's monocytes and lymphocytes that are impacted, and the lymphocytes more. White blood cells have the same ability, and when there's inflammation or infection or a reason why our white blood cells are activated, the chemicals that are released by damaged tissue, whether it's a cut, a bruise, an infection, an invader, whatever, the chemicals they give off are able to facilitate white blood cells. They make them being able to, they open little openings, little clefts in capillaries wider. The white blood cells are more readily going to attach to the borders, and they could actually scooch through, just the way somebody parks next to you and you can barely open your door to get into your car. You've got to kind of go in sideways and squeeze your way in. That's diapedesis. And once they're in the tissue, they can make their way along to get to the area. Okay. So this is really fascinating. And yes, there's molecules that they adhere to and carry them, but by and large, it's a type of positive chemotaxis. Those chemicals are facilitating or enabling those white blood cells to get where they're going and start a process that's very famous called inflammation. And inflammation is good. That's what your body's supposed to do. Doctors and clinicians and nurses get worried when something should be inflamed and it isn't. You twist your ankle, it should swell up. Okay. You get a cut, and all of a sudden, that cut, what's this? I had 2 days old, not red or inflamed. What's going on here? I mean, for some reason, there isn't enough white blood cells, or isn't enough circulation to get there. So, when something is not happening that should be happening, that should set your antenna going. These are the things you look for. The absence of the thing is just as important as the presence of a thing, if you want to think of it that way. By and large, they work by gobbling up things, phagocytosis. Not all, but that's a good generalized description. The response, the so-called inflammatory response, is just this. It's trying to bring things in that are going to hold whatever, not just infection, but hold the damage in one area so it can be addressed. Okay? The basophils are an interesting cell. They're the least abundant, but they're very important. When they leave the bloodstream, they become something called a mast, M-A-S-T cell. And that cell is filled with those blue granules have heparin and histamine, and they are the ones that dilate the little capillaries to allow the white blood cells to get out. They increase the circulation of the area. They're directing blood flow to the area. So basically, the reinforcements, the troops are coming to fight a battle. They open the passageways for them, and they prevent blood from clotting. That's what heparin does. And so initially, that's why things get red, hot, inflamed, and swell. And we talk about this. We talk about immune system, what are called the cardinal signs. We will get there. And there's the positive chemotaxis. Here it is. They make those little clefts bigger. The chemical's attracted, and it's going to where it's supposed to go. And it doesn't mean anything that would. It doesn't have to be a puncture wound. Anything that causes damage, even if it's a normal a process inside that causes damage. It's there. You don't have to break the skin. I mean, again, a sprained ankle, you don't have to break the skin. It'll cause cellular disruption. But inevitably, if something disrupts the skin, it's like a projectile or an eye stepped on, it's going to have microorganisms on it, and it's going to be a much larger response, as you can see. Now into the specifics. The ones that are, we look for the numbers. And what I will do when we get together, probably the next time or Friday latest, like I said, I'll cook up one of my lab tests. I think most recent ones are about a year ago. And you understand what we look for when we're looking for infection or looking for irregularities. What we want to do is to discover irregularities in these numbers. So we know what the normal is. Let's say it's an average is 50 to 70%. If it's elevated, if your white blood count is elevated and this part of the white blood count is elevated disproportionately, let's say it's 80%. Now you start to think, oh, not only is there infection, most likely this is bacterial. Okay. The granulocytes, again, they call it light purple, whatever. It's neither. It's sort of between red and blue, but not very distinctly red or distinctly blue. So it's neutral staining with the terms to acid and base. It's not 2 to 5. It should be 3 to 6. They're called polys or polymorphonuclear leukocytes also, as well as neutrophils. Neutrophils for their staining capability. Polys, okay, because and it's not that they have it's sections. Again, it's just basically think of it as a sphere, a balloon, the nucleus, and you twisted it and twisted it and twisted it into, and the more you twist it, the more sections, and you'll see this very shortly. And they are the first ones that they're on the scene with any kind of problem. And depending on the chemicals, eventually, then you might see if it's a viral infection, you're going to see there's going to be more lymphocytes. And this number won't rise. If it's bacteria, this rises. They are very aggressive phagocytically. Again, we call them bacteria slayers sometimes. The eosinophils, the eosin is the red or acidic stain. You get red granules. The neutrophils, eosinophils, and basophils are characterized by that nucleus that's got at least, in neutrophils, 2 twists. And eosinophils, we call them bilobe. There's 1 twist, as well as basophils. We see them in allergic reactions. It's not just worms. So they just constantly talk about worms. You might see this in somebody has their well waters contaminated with giardiasis. You would see an increase in this. You might see an increase in this with somebody with malaria. Because when they talk about parasitic infections, parasite's a general term. Parasitic infections typically applies eukarya from micro. So we're talking about protozoans, we're talking about worms, sometimes we're even talking about fungi, and a lot of times associated with allergies. And these are a small but not minute section, these red granular ones. And this is what they look like. Here's the eosinophil, distinct red granules. See, almost like that little pinpointing pattern. Whoops. And you can see the different staining. This is neither red nor blue, but you can see 1, 2, if you want to consider that 2, 3 lobes. Here you just have 2 lobes. So it's 1 nucleus, it's just the folding that goes on. They're bigger than red cells, as you can see. The basophils, very little but profoundly those blue granules, the how is it stimulated? Histamine dilates blood vessels. And histamine, when it's released in certain areas, can cause significant problems. And it's the cause of asthma and even anaphylactic shock. Excessive amounts there because histamine in the bronchi, in the tiny bronchioles, these teeny tiny air passageways, doesn't cause them to dilate, it causes them to constrict. That's what asthma or anaphylactic shock. And the heparin stops the blood clotting. Very tiny amount, again, typically bilobed. The monocytes, the largest, when they leave the bloodstream, they become macrophages. So the ones who change, basophils become mast cells, monocytes become macrophages, and macrophages are your sort of like your body's biological cleanup detail. Every time there's damage, they gobble up dead cells, tissue debris, infections, viruses, poisons, bacteria that have been neutralized, any of those things. A fairly large amount, 3 to 9, 3 to 10, longer lifespan because they're the busiest. They have one nucleus as the others, but it appears as uniform. It really is not. It's not lobed. It has like a U-shaped indentation, or the one they show you here is a kidney-shaped indentation, and they're by far and away the largest. Here's the blue granules for the basophil. Look at this; is about twice as big as a red cell, easily, maybe 2.5 times. And you can typically, this is a typical kidney shape, but sometimes they even have a U shape like that. And so erroneously, it's not really a lobe; it's just the nature of it. And you can see you can't see the granule. I mean, here they're very distinct. Here, say, even though there's granules in there, they're just not as noticeable. The second most abundant and what we see the most of, if somebody's got a viral infection, lymphocytes. They're the smallest, but they're still larger than a red cell. And it looks like it's all nucleus and just a little bit of cytoplasm. I mean, it's the size that has to do with it. It's not that there's less cytoplasm. I think there's just the proportionality of the nucleus to cytoplasm. Because when you see things under a microscope, a lot of times it's almost an optical illusion. The ones that you typically see are T cells and B cells. Down the road, we'll look at the B cells in the immune system that changes to plasma cells. They look different. And we'll get into what they do. 25 to 35, probably about average for most authors. They live a long time. They're real, and we'll get into it. That's where the immune system chapter is really, and you can see it's just a very large nucleus and relatively scant cytoplasm. But you're looking at a three-dimensional structure, two-dimensionally. And so when you get, and this is his average, most labs 4.5 to 10.5, even 11. You get above 11 without a good reason, like somebody's dehydrated. Okay. Someone's just getting over something, where we have some context. That high white count called leukocytosis typically, I mean, we're not talking about these kinds of things. Now we wonder, I'm going to talk about different ways that can we tell whether it's acute or chronic, or whether it's in the early stages or later stages. That's another one of those immune system discussions. Versus low white count, classically associated with chronic illness like AIDS. I mean, some anemias. I mean, when you're looking at a chronically low white count, I mean, it typically with viral infections, when they're acute, the white count goes up, not down. And I would take issue with this. Okay. And so we'll look at and I'll go over this when I show you one of mine, what a differential is. The differential is counting the percentages of neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And we take a look at those. And there's different ones. The with classic mononucleosis, typically they look at in terms of lymphocytes. Eosinophils, yeah, I'll buy it in worms, but we'll see it in a lot of allergic reactions. And you see it in other infections. It's not that. The monocytes, again, I would focus more on the lymphocytes than just looking at the monocytes. The neutrophils, bacterial infections. And anytime you see a lack, now we're talking about, you start to worry about AIDS. When you see an absolute low, you start getting those low numbers. Either something bad's happening, there's some bone marrow disease that's not letting stuff out. And I'm getting more into that as time go on. And then the last little nugget I'm doing with again is the difference between acute, sudden onset, chronic, long term. When we see acute leukemias, and again, whether it's in the lymphocyte, monocyte line, or the other lines like neutrophils, eosinophils, and basophils, uh, if it's acute, it's not good at all. And typically, we see that in younger people, very, very difficult to treat. Uh, Chronic is something that's considerably more treatable, and we typically see in folks who are older. I realize that's broad brush painting, but effectively, what happens? Those white blood cells, oh, you don't have proportionally, platelets can't get out. There's not enough of them proportionally. You know, bleeding problems. The white blood cells, even though there's more of them, they're not healthy white blood cells. They don't do their job. There's not enough red cells, so you get pain that's associated because there's not enough oxygen carrying capability. The platelets, again, all the other factors aren't doing their job. There's a lot of different treatments. It's really not part of our course for here. The bone marrow transplant has probably been the most valuable of all of these. And I'm stopping it here. Thanks very much. Everybody, I hope we'll be back on track and good, normal for Wednesday. And I will see you then. Bye bye.